So weird to say that, but
Industry.
it kind of happens. That kind of happens. So we'll go from there. Again, informal per usual. Ask questions as you guys feel free. We'll kind of go from there. Stand, sit, whatever you like. We'll kind of go from there. Feel it out. See what happens.
Great. Well, thanks so much for having me. Really nice to be paired up with Danielle. What I want to do today is just give you a little bit of an overview of some of the work we've been doing over the past, almost 10 years now. It focused on text messaging for depression in particular, and then give you a little preview of some of the stuff we're doing going forward with the current R1 that we have. So just to give you an overview of who I am, I'm primarily based at UC Berkeley in the School of Social Welfare, and I also have a 25% appointment here in psychiatry, based mostly at the General Hospital, where I also work with the Center for Vulnerable Populations. I'm a clinical psychologist by training, so it's kind of nice to be in the mental health trifecta. All right, great. So just a big picture thing that I think is interesting to present. I don't know how many of you are aware with the hype cycle, Gartner's hype cycle. Has anybody in this room at least? No one's aware of this? Okay, cool. So it's pretty new. But I think it's good to provide perspective in terms of thinking about the technologies that we're using in mHealth and digital health broadly. And I think especially having been in this world for about 10 years now, seeing some of the rise and fall of the hype of apps are going to just fix everything. We're not going to need humans anymore. To now it's like, oh wait, apps, nobody really uses them. It's hard to engage users, etc. So this is one that was done, I guess it was a couple years ago, a year and a half ago. And so we can see that when a technology trigger kind of comes in, there tends to be this peak of exaggerated expectations, right? So right now we're probably in the AI. AI is going to fix everything, machine learning, and so on. And then we actually test these things out. And then it's like, oh, wait, there's problems, right? They either didn't work the way we thought they were going to work, or there's unintended consequences often. And I think we're focusing a lot more on these unintended consequences now compared to 10 years ago, for sure. Then we enter this trough of disillusionment. So things like Google Glass. Where is Google Glass, right? Some activity trackers. FieldBand isn't even around anymore. This is when we think about maybe abandoning this technology and maybe it's not going to do what it was promised. And then moving a little bit into the path of enlightenment and to the plateau of productivity, where we can actually find ways to utilize these things. Maybe not the way we thought they were going to work early on, but they can move forward. And the reason that I present this is this kind of happened with my work in using text messaging, right? It was one of the first mobile technologies to be utilized in health interventions, and we're like, oh, we're going to do so much with texting. And then after a while, we're like, that's texting. That's so basic. It's boring. Apps are coming on. But we're starting to realize that there's actually an important role of messaging. It's basic, but it's multi-platform, and something that we can leverage in a variety of ways. So hopefully I'll give you some examples of how we can do that. And maybe you can put your technology into this graph and see where it is. So the context for my work is conducting cognitive behavioral therapy for depression in the public sector. As I mentioned, I'm a clinical psychologist, so a lot of my motivation has been clinically focused. And what I encountered in my work and some of the research that we did in the setting at the General Hospital primarily is low levels of engagement, high dropout, not completing full treatment, and low engagement with homework, which is a core component of CBT. And we know that attendance predicts improvement. So the more you show up to a session, the more you engage, similar to what you do with an app, right? The more you actually use it, you're going to get better results. So these are some of the issues that we're trying to address. This is what a naturalistic kind of view of attendance in these CBT groups looks like. So you can see a lot of people come for 1 or 2, 3 sessions, and then it just drops off precipitously. There's a little bump around 16. That's when ideally we would want it. But then there's people who just stick around for a long time and never want to leave. This is what the real world looks like when you're thinking about engagement in these types of interventions. What we want to do is try to have a big peak around 16 or so. That's the goal. So we want to move this bar over to the right as much as possible. So then the goal is, how can we leverage text messaging to improve treatment quality engagement? Again, thinking about the context, we started this work in 2009. Apps weren't quite online. It was mostly texting, particularly in lower income settings. It's the technology that's most widely available. And so, again, cost efficient, easy to use, high engagement rates. And one thing that we kind of discovered later on, it wasn't an initial motivator, but there also seems to be a sense of, more of a sense of personal connection when we're thinking about text messaging. It's inherently a social technology, right? What do we use texting for? Typically to engage with other people. And that we're seeing is useful in utilizing it in the health context. So we developed a text messaging adjunct to cognitive behavioral therapy. So people are using this, or participating in this text messaging program while they're in CBT for depression. So the general structure of the treatment is meeting weekly in person in a group format for 16 weeks. There's 4 modules, 4 weeks each, focused on core messages of CBT, working on thoughts, activities. There's an interpersonal component, and then 4 weeks talking about health. This is because we're in a primary care setting where people have multiple chronic illnesses, so we'll talk about issues such as sleep, exercise, etc. There's rolling admission, so people come in and out. So we did this work pretty much nonstop from about 2010 till 2018, and in some form or another, starting from pilot work to an actual clinical trial. And in the clinical trial, most of the data that I'll present a variety of data, but in terms of the actual trial, there was a control arm that received standard group CBT, a manualized version of CBT, and then there's one that received that same intervention with the text messaging adjunct. So we wanted to look at the differences in outcomes and engagement with in those 2 interventions. Delivered by myself, so that is a limitation. Tried as much as possible to be to treat all patients the same, and another social worker or psychologist. All right, and so this is a general overview of the characteristics within the clinical trial, and I've highlighted some of the points that I think are of interest. One is the age. So average age is around 52 years old. So there's similar in both groups, which is important, right? We want to know that we're comparing groups that are relatively similar. But this is an older group in general in terms of thinking about using technology. Oftentimes when we think about technology and texting, we think about teenagers or adolescents, right? Maybe Hope Lab's focus, and less so on populations that are a little bit older, 50s, particularly thinking that this work was done about 5 years ago. So that's something I think of note to consider in the context of the outcomes and so on, and hopefully in the impact. And also the education piece. So these are all Spanish-speaking Latino immigrants who primarily have low levels of education. And so we often focus on cultural differences, which are important, something that we pay attention to in delivering the content, but education is a really key component, and something that we'll see will impact some of these findings. Because ultimately we're still engaging with text, with dealing with issues of health literacy, right, that are underlying a lot of these problems. And then down below, we'll see that most people had a mobile phone prior to engaging, but not everybody used text messaging beforehand. So we had to teach some folks how to use text messaging. And this obviously changes over time with more people owning mobile phones and more people owning smartphones over time. So this is the core aspect of homework that we ask patients to complete during the week. It's a quick mood scale. Indicate the day of the week on top. What was your mood overall in that on that day? And then there's another question down below asking, for example, how many healthy activities did you do each day? So what we want to do is take this format, but turn it into a texting format. And then we ended up adapting it a little bit. But the mood aspect of it is the core element of our intervention. So we coined this intervention mood text because it's so heavy on mood. So we sent out mood monitoring messages, what we call a theme-based message, something related to what we were talking about in session, medication reminders, and group attendance reminders. This is what the mood monitoring message looked like. So Emma, so first the name of the person. What is your mood right now on a scale of 1 to 9? 9 being best. Respond with a number and message about what you're thinking about. And these were sent out randomly at any time between 8 a.m. and 9 p.m. And then we provided feedback 20% of the time at a variable ratio schedule. So those psychologists in the room will be familiar with this from your initial Psych 1 textbook. In that this is a schedule that provides highest levels of response and most resistance to extinction. So the way we're all familiar with this is slot machines. Right, slot machines do this really well. This is why people come back to slot machines. You get feedback. You don't know when the feedback's coming. You're probably going to win something, and so it kind of keeps you pushing that button. Here we're trying to utilize that aspect of human behavior in a positive way, where people are engaging in this hopefully healthy intervention. So we want people to respond more to messages. This is an example of some of the feedback that we tailored it roughly into 3 categories: high, medium, and low. So if you responded with an 8, it looks like you're feeling good. Think about what you're doing and thinking to keep your mood high. So we want to reinforce those activities that people might be doing. Or if it's a middling mood, what thought would help you feel better right now, right? Or what can you do to feel better? So there was a bucket of about 15 messages that would be sent out. This is what a theme-based text message would look like, usually sent in the evening. Some of them are questions, kind of rhetorical questions. People would respond sometimes, or something more directive. Do an activity that you enjoyed in the past. And these developed during our pilot phase, where we were asking kind of the same question, more similar to that sheet, and we started making them a little bit more varied and tied a little bit better to even what we talked about that week. Medication reminders at whatever time people were taking, either morning, afternoon, evening, etc. And then a group reminder text. So the day before session, asking, are you coming to group this week? And that was helpful also. As a clinician, we have the dashboard where we can see this data. We can get a sense of who's going to show up or not. And this is what the mood graph would look like. So this is an individual. This is their mood. You hover over, and as a person's name here, it's blacked out for privacy. So they reported an 8 on a computer looking up information on health. So we might review what were thoughts that were going on around this. Right, we're talking about thoughts. We're talking about behavior. So that's a healthy behavior where you're starting to engage in something. Did you follow through, et cetera? So it gives us a targeted place to intervene. We would then probably look through, well, what happened here when you were at 5, and try to troubleshoot that as well. And then down here are responses to the theme-based messages if they did respond. And we can look over time what mood looked like. We can also graph PHQ-9, which is a depression measure over time. So the overall results of the study, we were unfortunately not able to find significant differences in outcome as measured by PHQ-9, primarily because, as you can see, by the end of the intervention, in the intervention group, there were 18 people out of the 45, and then 9 people out of 39. One was ineligible. So there was a big drop-off. This wasn't a K project, so we didn't have a lot of funding to follow people up. That was a downside. There's some indication that there are differences in terms of the PHQ-9, but nothing significant, obviously. Where we found the most important findings out of this study were looking at engagement. So first in total sessions attended. So if you noticed back in that, this is similar to that graph that we saw early on. And in the control group, you see there's again a high bars in the 2-3 sessions attended. So the median here of sessions attended was about 3 point something. I forget the exact number. But we were able to move that, or the texters attended about 6 sessions. So about double the number of sessions attended when they were receiving the text messages. And even more dramatically, texters were in treatment more weeks. So this isn't to say that they attended out till the 13th week, but that could have been their last week. So maybe they attended 5 sessions, but they skipped a few in between, if that makes sense. Whereas the non-texters were still around the 3-4 week mark, where it was typical for them to drop out. So this is where we see the biggest differences in the intervention. And I think what I attribute this to a lot is thinking about folks with depression who are not very motivated to show up. Maybe you miss a session, right? Maybe you're not feeling well, something's coming up in life. The next week you miss another session. By that point, your odds of returning are really low, right? And that happens to all of us in going to the gym or whatever new habit we want to develop. But for the texters, they're still getting these messages constantly. We're still bugging them, right? So that day when they start to feel a little bit more activated, a little bit better, a little bit motivated, they have a reason to go because there's still a connection with the group. So the implications are that the text messaging adjunct can lengthen the stay, lengthen the stay in treatment, which hopefully will help us help more people get better, right? So to amplify the actual impacts of this intervention, which we know works, but people don't always get the full dosage. And then some other things that we're able to look at with this data are thinking about how does this data help us predict important events, such as predicting future attendance. This is a project I worked on with a postdoc who now works with Danielle. And we wanted to see, does texting behavior between sessions predict whether or not someone's going to show up? So we have some mood monitoring text responses, some data around average response rate, average response delay, mood, and then the day before session, whether or not you responded to delay in your mood, et cetera. So does that predict whether or not someone's going to show up? Controlling for prior week session attendance, because that is the most important variable in determining whether or not you're going to show up. It turns out that prior day mood is the most important variable in determining whether or not someone's going to show up. That makes total sense, right? If you're not feeling that well, then you're less likely to get up the motivation to go to session that next day. So if your mood is 1 point lower, you're 32% less likely to show up to session. So having that information is really valuable because then we could develop targeted interventions around that data point, where we could either send a message targeted around that data point. We could call you, we can go knock on your door if we have to, right? The intervention that comes later can be worked on, but at least we have that foundational information. So we can identify critical points and provide outreach to patients, either automated or clinician-based. And then we also looked at, because of this data, we wanted to look at whether these mood ratings were tied to the PHQ-9. Are they linked in any meaningful way? And we found that indeed, for the past week, your average mood for the past week was related significantly to the PHQ-9, and your mood today was related to the PHQ-9. Interestingly enough, your mood in the past 2 weeks, your real mood that you reported, was not related significantly to the PHQ-9, which is a little bit weird because the PHQ-9 purports to measure your mood in the last 2 weeks. So either the PHQ-9 is not measuring your mood in the last 2 weeks, or there's something wrong with the mood ratings people are providing. I think that's interesting because I think clinically we have a sense that 2 weeks is a hard time frame to think back to. 1 week seems to be easier for people to think back. So we're very biased towards the past week or even today. So potentially, given this information, we might be able to use simple mood ratings via mobile phone to assess symptoms, maybe at a broad population level, and may allow for better remote monitoring. Some other folks have done this by sending one message a week, asking how depressed have you been in the last week, and have found similar relationships. So I think those are, again, simple opportunities to do broad level assessment that can then inform decision points, especially in this era of depression screening in primary care, et cetera. Some of the feedback that we've gotten qualitatively, I think, is important to kind of round out the experience in using these interventions. And so what folks have often mentioned, we did some work, we've done some work with English speakers, although that wasn't in the formal trial that I reported. We have some data on that. And they've often mentioned that they trigger self-examination, allow people to check in with themselves. And these were all things that we want to do with mood monitoring. Sometimes I'm so busy, I hardly stop and think about how I feel. Now that I'm getting texts, I stop and think every day. When it stopped, I missed it. My life is so crazy, I need a reminder to think about how I feel. Right? This was kind of a natural experiment. There was a bug in the system, and it stopped for a week. And so, but this patient stated that she missed it. And I think this is also pretty, it's a good example of how a lot of our patients at the general have extremely stressful, we all have stressful lives, right? But I think there's something particular about struggling for resources and being just very stretched, having a lot of health problems, et cetera. Spanish speakers mentioned feeling motivated, feeling cared for and supported. The most positive thing about receiving text messages is when one is in a difficult moment and a message arrives, I realize that someone cares for me and I don't feel alone. And again, there are people that care about me. So you can probably start to see some differences in the types of responses. And this prompted, it wasn't surprising. So some of the work I've done in the past is kind of based around cultural psychology. And we know that folks from kind of more mainstream American upbringings have the more individual focus, right? So we kind of individual versus collectivist, relational versus autonomous. And so we see some of that come out. And I think this is really important in thinking about how are our interventions received by people who get them? We assume that, especially technology-based interventions that are standardized, everyone gets the exact same thing. You must experience it in the same way. That doesn't seem to be the case, right? We bring ourselves to the intervention. And I think that's something really important to consider as we're developing. So we're exploring this a little bit further to see how this impacts outcomes, engagement, etc. Some of the downsides that people mentioned are being busy when they get them, not being so easy to text for some folks, particularly older folks. One person did say that he wanted to stop receiving them because they weren't sent by a human, they were automated. But by and large, people, even though, so most of these folks, they knew that it's an automated system. And that's what I think is most interesting, is that it's an automated system, yet they have this sense of feeling cared for. Right? They know that I and my team developed it to be sent to them, so that probably helps a little bit, but still, they're automated nonetheless. Just make sure I'm on time. Okay. And then some things to consider, I think, again, in developing these types of interventions are issues of digital health literacy. And here is just a correlational table looking at response rates and so some general engagement with the intervention. And what we see is that the higher your level of education, the knowledge of how to text before the intervention, and whether or not you texted in the last month are significantly related to responding to messages. So that makes sense, right? But it's still important to consider that as we're matching technology with the user and their abilities to engage in these interventions. If something as simple as number of characters in the messages, right? So it makes sense that people who are more educated are going to respond more. They're going to provide you probably more data, more rich data, but what does that mean when you're comparing those folks with the folks that are not responding with as many words? Right? So broadly, the lessons that we've learned from this study is that patients who text 10 more and stay longer, mood ratings can approximate PHQ-9, prior day mood predicts attendance, and generally patients like interacting with automated text messages. So that's some of the work that we've been doing, and we're trying to see if we could maybe broaden that out to other settings and maybe do a more formal assessment to find out whether depression outcomes might be different in particular. But one of the things we're moving onto, we have a current R01, my colleague Courtney Lyles and I, about looking at texting to improve physical activity among folks with depression and diabetes. So why depression and diabetes? So they tend to be highly comorbid, and they negatively impact each other, particularly among low-income communities, among Latino communities, African-American communities, very, very high rates of diabetes. So the one good thing about physical activity is that it's a common element to both of these. Behavioral interventions targeting both. In depression, we might call it behavioral activation. But a lot of it has to do with engaging in physical activity and new activities, et cetera. In diabetes, we might talk more about exercise. So some of the issues that we want to kind of address with this intervention are personalizing intervention. So our previous intervention was not that personalized. There was a little bit of feedback that was provided, but it wasn't particularly personalized. Most people got the same intervention. Integrated into care, we did some of that before and we found some value, so we want to continue that. And developing them with vulnerable populations who have the highest burden of these health problems. And some of the challenges in engagement. So if it works in these populations, if we design for these populations, it's going to be easier to then expand out, is our view. So this is based on a previous study by a colleague over at Microsoft Research in Israel, where they passively collected step counts on an app and then sent feedback messages, either statically or adapted. Adapted meant that an algorithm was set up to send you a message based on the steps that you walked that day. So if you walked high steps, it would send you, let's say, a socially based message if you responded to that. And the algorithm would learn which types of messages you respond to, so it kind of starts to adapt the types of messages that it would send you. And so it was kind of a relatively basic study where they had about 4 types of feedback, but they found some increases in activity, and even some decreases in A1C levels. So that's a primary measure of diabetes. But it was a small study, like 30 people or so. So even considering how small it is, the results were interesting, which caused us to think about how can we apply this more broadly. So we're using a similar approach, collecting steps and then personalizing messages using a reinforcement learning algorithm. The reinforcement learning algorithm is a type of machine learning algorithm. It's relatively straightforward in that it determines what it's going to send you based on the data that you're providing. So it's going to send you a message, let's say around physical activity within a social context. If you respond to that, that social context is going to get a higher weight, a higher likelihood of being sent out to you. And so there's a few variables, and I'll tell you which ones we're looking at in a bit. But just in terms of the setting, it's still at the general hospital with English or Spanish speakers, and we're going to compare either a static intervention, something more similar to what we had in the depression work, which is more common in texting interventions. So now there's texting interventions for almost everything, but they all tend to be pretty static. You get the same thing on day 1, everyone gets the same thing on day 1, everyone gets the same thing on day 10, etc. Or a reinforcement learning intervention. So kind of a way to understand it is that we're going to send feedback on your physical activity, so how many steps you walk, and then a motivating message to get you kind of moving, which is all going to be dependent on the step count via your smartphone. This is an overview of what the intervention is going to look like. So the static message is kind of on the side, the diabetes message and depression messages, which are more kind of educational in nature. And then the physical activity is what's going to be personalized. Here are the personalized messages. So one message will be sent providing feedback on steps. So you get one of these messages. So you met or did not meet your goal. Yesterday you walked however many steps. You walked these steps. You can do better. So that's if you didn't meet your goal. Or you walked these steps. Great job if you did meet your goal. So that's one message. And then the next message will be a motivation message, which will be in these categories. So capability, these are taken from mostly from the COM-B framework, which is it's an implementation science framework that kind of brings in a variety of theories. So some are focused on capability. So how can you engage in behavior? Maybe it'd be something like, try going for a walk early in the morning, right? So kind of tips on how to do it. Opportunity opportunity would be more on what you can do. Capability, so that's how, so let's say going with other people, right? So that would be a how. And then something around self-confidence, which is building self-efficacy, maybe some inspirational messages, etc. And then within these categories, there's social or individual messages. So either doing things on your own, or maybe doing things with and for loved ones, etc. So the algorithm will then start to personalize what messages people get based on what they're responding to. So we want to assess the impact of algorithmic personalization, and hopefully testing this again in a resource-constrained environment can have broader implications. And thank you to all the people that have helped and the funders and so on. So, thanks.